Hi PTA students, it's Lisa talking to you today about posture. PTAs need to know what ideal posture is. We are always observing our patients from the minute they get up out of the chair in the waiting room to the time they go back to our gym. We are looking at their posture. So why is it important that we know what good posture looks like? Why is good posture even important? Good posture is important because it helps your body function and helps your patient's body function at an optimal level. It promotes movement efficiency and endurance, and it contributes to an overall feeling of well-being. So those phrases like stand up straight, don't slouch, the things your mom always said, those are not just phrases that can be sloughed off. Those really do help you maintain your best level of function. Now, posture can be thought of as either static or dynamic posture. When we're static, we're standing still or sitting still. When we're dynamic, we're moving. So both of those posture types involve control of our body's parts by our skeletal muscles. They work in a coordinated response to each other, and it works also in response to the forces of gravity. Good posture involves balance. Generally, people with better balance might have better posture. Posture involves balance because our balance system is what keeps our center of mass within the boundaries of the base of support. So posture is achieved through our central nervous system integrating all of these systems, our muscular system, our balance system, a little bit of our brain as well, and some vestibular stuff plays into posture and balance too. So a review of the normal postural curves. Now our spinal curves are a series of counterbalancing anterior and posterior curves. These curves must be maintained when we're at rest and when we're doing activity. They act as shock absorbers and also help reduce the likelihood of injury. So normally we have cervical lordosis, thoracic kyphosis, and lumbar lordosis. You think a person with faulty posture probably has the potential for being more injured. Again, that's why it's important we know what ideal posture looks like and how to correct faulty posture so that our patient will be having reduction of injury potential. Scoliosis is a lateral curvature of the spine. You guys don't need to know too much about scoliosis for the purposes of this class, unless we happen to observe it on some people. When we come into lab, you might see one of your classmates have it. So, scoliosis actually affects about 49% of the population. Scoliosis is named for where the curvature is, the convexity, You can have thoracic scoliosis or lumbar scoliosis. This is showing a thoracic convexity. This is showing a lumbar convexity. So this would be called the thoracolumbar scoliosis. This might be called a lumbar scoliosis. You can have the curve in the thoracic spine or the lumbar spine. You can have both, a thoracic and a lumbar. You could have double scoliosis. That would be really a bummer. Normally, if you observe this in your lab partner or in a patient, a normal spine in a forward flexed view looks like this. A scoliotic spine in a forward flexed view will look like this. We can see the lateral curvature. We also see some deformity of the rib area because of the curvature in the thoracic spine. I'm hoping this is review for you from kinesiology. But I want to just review what happens when we have a lateral tilt posturally. Here we have the right hip abductors contracting normally to keep the pelvis steady when the left leg is lifted. But when the right abductors are weak, this would be looking at a frontal view here from the front of the patient's body. When the right side abductors are weak, the left side of the pelvis drops. Okay, you remember Trendelenburg gait? We're going to start to see some of that when we look at each other from the anterior and posterior view, looking at a lateral tilt to the pelvis, potentially. So when we are newly born, all of us have one curve that is a flexed curve. This is called a primary curve. And as we develop our postural curves, we develop our secondary spinal curves coming into cervical lordosis and lumbar lordosis. So again, we start with one primary flexed curve, and as newborns develop, at about 2 months or so, the newborn starts to be able to lift their head, developing that secondary lumbar lordosis or cervical lordosis curve. And as they're able to do tummy time, that's when we start to develop the lumbar lordosis. You guys, I don't know who this baby is, but you know, they're working hard at tummy time. I should have put a picture of my twin grandbabies on here for you, but you know, I did make them do a lot of tummy time so that they could develop their postural curves and develop good head and neck control. But I don't have a picture of those two. Maybe I'll find one and show you in lab, because I think they're awfully cute. Anyway, again, here's review our normal curves. The secondary curves are developing at birth, or during that newborn phase. Now, in our normal ideal posture standing, our head is erect and in a well-balanced position. What that means is you're not tipped off to one side. We see those normal spinal curves. Okay, our chest and our upper back are positioned optimally so that we can breathe easily. With too much forward shoulder, it makes the chest cavity come more concave. It gets harder to breathe. In normal static standing posture, the pelvis is neutral, and all the bones of our lower extremities are in ideal alignment for weight bearing. So you guys, we're made to stand up. We're made to move and stand and walk, and it's just great how it works out that all of our our bones are in ideal alignment for weight bearing. Our pelvis is neutral. We can breathe easy. We've got good spinal curves for shock absorption and no injury. And our head is erect so we can see danger on the horizon. It just works out great. I want you to start thinking about what happens in the muscles as we're in ideal posture. So in ideal posture, we've got an equal pull between the neck flexors and the neck extensors. We've got an equal pull between the trunk extensors and the trunk flexors. We've got an equal pull between the hip extensors and the knee extensors. It is normal to see some postural sway. Everybody has a little bit of it. Postural sway is controlled. It's a constant displacement anteriorly and posteriorly. It's a constant displacement and correction of our center of gravity within the base of support. So our ankle dorsiflexors and our ankle plantar flexors, our tib anterior and our gastrocs primarily, help control our postural sway. So here we have the gastrocs controlling so we don't, fall forward and land flat on our face. Here we have the tib anterior controlling so we don't go backwards flat on our back. So what does this mean clinically, though? So generally, we have, when you see somebody that has a higher center of gravity with a smaller base of support, that's going to increase their postural sway. So clinically, that means somebody standing with their feet closer together is going to probably have more postural sway than somebody with their feet further apart. Okay? I put this slide in here to show you guys for your reference. I'm not sure if we'll use it in lab or not, but if you would like to download it and bring it with you, you certainly can. One reason why I don't like it is because it's a little outdated here. It looks like the type is from about 1950, and it's tedious to score. Okay, so but it's got good visuals. So this column here is showing what good posture looks like at the head and the shoulders and the spine and the hips and the ankles and the neck and the upper back and the trunk and the abdomen. This is showing fair posture. You see this, the head is starting to tilt a little bit to the side here, and it looks like one shoulder is starting to, oh sorry, the spine's got some curvature. One shoulder's starting to drop, and the hips are not as even, okay? And then really poor posture, you can see the head here is going really wonky. That's a clinical term. And the shoulders are totally wonky too. So if you guys want to look at this, and if you're the type of person who likes a lot of visuals, you certainly can, because it's got a nice grid outline for you, referencing ideal posture versus, you know, what that would look like on the grid if it was poor. But you don't have to download it unless you really want like numbers and charts and that kind of thing. So in ideal postural alignment, I have a slide in a little bit that will show you the bony landmarks, but this is showing a plumb line. We're going to pull these out in lab. Hopefully we'll be able to do them outside since the weather's nice. The plumb line going through the bony landmarks. Ideally here you've got, again, equal pull of the musculature on both sides of the spine and the hips and the knees. So we do have primarily three different types of faulty postures that we see. Again, you're observing your patient from the minute they get up out of the chair in the waiting room, or the minute you go into their room and try to get them up out of their bed. Ideal alignment here as compared to the faulty alignments. Now in a kyphotic lordotic posture, we're going to see some increased cervical lordosis, increased thoracic kyphosis, and increased lumbar lordosis. So the head is forward, the cervical spine is hyperextended, the thoracic spine is flexed, the lumbar spine is hyperextended, and at the pelvis here we have an increased anterior tilt. So thinking about what might be happening muscularly, the muscles that might be long or weak would be the cervical flexors, especially the lower cervical flexors. The upper cervical spine is likely extended here. So the lower cervical extensors, or flexors, sorry, are long. The thoracic extensors are long. Your hip extensors are elongated, and your back extensors are elongated. Your abdominals are likely elongated as well. Potentially what could be short here would be the upper cervical extensors. The lumbar extensors are tight and short. Your hip flexors are tight and short. Weakness, you might see weakness in the deep neck flexors, especially the lower ones. You might see some weakness in the thoracic extensors. They're basically overstretched and long. Probably are going to see some weakness in the abdominals being overstretched and long here. You might see some weakness in the glutes as well and the hamstrings because of that anterior pelvic tilt. Okay. In a flat back posture, we have the thoracic, or the entire thoracic spine and lumbar spine really actually very flattened here. So the upper thoracic spine is flexed, the lower thoracic spine is straight, and the lumbar spine is straight, if not a little bit flexed. Okay, we've got an increased posterior tilt of the pelvis here. So what this might look like muscularly is the long muscles are the cervical flexors, the lower cervical flexors. You've got your upper thoracic extensors long here, here. You've got your lumbar extensors long, right? And we've got your hip flexors in that posterior tilt. Your hip flexors are going to be long. Potentially weak muscles could be those upper thoracic extensors. Your hip flexors might be a little bit weak, and your lumbar extensors are a little bit weak. I'm pointing these weak muscles out because I want you guys to start thinking about, for your next class coming up in therapeutic exercise, what you might need to stretch or what you might need to strengthen in an exercise prescription, okay? In a sway back posture, we've got the cervical spine, the head is forward, the cervical spine is slightly extended. Compared to this flat back posture, we've got, the cervical spine is hyperextended. So the upper thoracic spine here is flexed, and it's sometimes called a long kyphosis of the thoracic spine. We've got the trunk displaced posteriorly relative to the plumb line. We've got the lower lumbar spine is flexed or straight, okay? Maybe the upper lumbar spine looks like it's a little bit extended here, but the lower lumbar is flexed. We still have that posterior pelvic tilt going on. So again, potentially weak might be those hip flexors, okay? Weak might be your thoracic extensors here, okay, because of that increased flexion of the thoracic spine. And then we also might have some weakness some weakness potentially in the abdominals as well. They're probably short here too, okay? So this again is showing the sway back posture with those muscles that I just pointed out. The flat back posture with those muscles that I just pointed out. And the kyphotic lordotic posture with those muscles I just pointed out. So in ideal posture, looking at a plumb line, ideally the plumb line should land, this is looking at a lateral view, through the earlobe, through the acromion process, through the bodies of the lumbar vertebrae, through the greater trochanter, just posterior to the patella, and just anterior to the lateral malleolus. Look at this. She is so good. Here it is, ideal posture in the flesh. Through the earlobe, through the acromion process, through the greater trochanter, just posterior to the patella, and just anterior to the lateral malleolus. From the front view, we've got the head extended and level. It's not side bending to one side or the other. We've got the shoulders level. Neither of them are up or down. We've got the hips level, no lateral tilt going on here. And the feet should be slightly toed out just a little bit when looking at it from the anterior view. Looking from the posterior view, again, we still got the head nice and level. The shoulders are level, the hips are level, and the feet here are just slightly apart relative to that plumb line. So here's ideal alignment in the posterior view. You've got a normal curvature of the spine here. We've got equal pull on the lateral trunk muscles, your QL and your internal and external obliques on the front side, slightly lateral too. We've got equal pull of your hip abductors with your adductors. We don't have any lateral pelvic tilt here, so we've got, looks like no weakness in either glute med. Okay, if this patient had scoliosis, you might see some tightness on that concave side of the curvature and some weakness on the convex side of the curvature. You've also got here in normal posture from the posterior view, you've got the feet are again slightly toed out, equal distance apart, slightly apart, and you've got an even amount of supination and pronation. So that means that your ankle, at the ankle, your inverters are equally pulling with your everters. wanted to show you guys the progression of lumbar disc pressure. I've been talking a lot about ideal standing posture. See, there's not much pressure on the discs. Probably the only better position to be would be laying down, either lying flat on your back, least amount of pressure, a little bit more pressure lying on your side. Here we have progressively worse pressure on the lumbar discs. From standing, it goes up when we sit. More pressure on the lumbar disc when we bend forward. Oh, when we slouch, just about equal. Maybe a little bit more pressure when we're slouching. And check this out. What happens when we bend forward with a weight? This is a classic way to blow out a disc, is bending forward with a little bit of rotation if you're pushing or pulling something, okay? And oh, this just makes my back hurt looking at them. Here we've got lots of lumbar flexion. We've got a completely posterior pelvic tilt, and they're holding on to a weight. So imagine what happens to those lumbar discs when you're sitting in poor posture and you've got 10 to 20 pounds extra on your frame. My back is unhappy just thinking about it. Again, we are made to stand straight and not have so much pressure on our discs. So they did some interesting research here challenging the notion that we used to hear all the time from our moms who meant well, just sit up straight. They actually did a functional MRI in 3 different positions. They evaluated the slouching position, they evaluated so when somebody is sitting up straight at 90 degrees, and they evaluated when you're sitting back reclined at about 135 degrees, thigh to torso, and they found that the 135 degree thigh to torso angle is actually best for sitting. That's the best position for your discs, okay? So there is strain on the discs when we sit at 90 degrees. You start to have more disc motion at 90 degrees and less at 135 degrees. So what that looks like here is, oh sorry, I want to skip forward to one slide. What that looks like here is in standing, you can see the disc. This is supposed to be like showing the disc in its normal spot, okay? You see that the disc is not bulging out too much, all right? There's even pressure on the discs, but look what happens when we sit up straight. There's actually even more disc bulge potential, more pressure on the discs here. See, that's kind of bigger than like that looks. And even better than that would be if we were reclined at 135 degrees, there'd be even less pressure on the discs. I'll go back to this slide now because this will show you some good tips that you can tell your patients who, a lot of them actually work sitting for 8 hours a day at the computer, right? So very, very good tip to tell them would be, hey, tilt your chair back about 10 to 20 degrees beyond vertical. That's going to help relieve the pressure on your discs. Try to put as much of your body weight evenly on all parts of your body as possible. What this means is your hips should sit slightly higher than your knees so that the bones of your lower extremity can take most of the force of gravity, okay? Even they could be a little bit higher than even this picture shows here too. To help good neck posture and shoulder posture, we want to tell them to not reach too far forward for their keyboard or their mouse. Again, for the neck, make sure their monitor, the top of it should be right at eye level here so that they can look with their eyesight just nicely at the monitor, not having to go into too much cervical flexion to see their monitor. And you guys, I'll just say it now, laptops are horrible. So if you're on a laptop right now, get off of it. Stand up. You know, if you're on a tablet, there's no good way to have good sitting posture, which you guys probably know after listening to one of my lectures and watching this video. Your neck is probably sore if you've been on a laptop. Sorry. So talk to you a little bit about handedness. We'll talk briefly in the lab if we have time, but I'll point out the slide now just in case we don't. Handedness is just kind of something fun to look at. So this is showing, okay, plumb line. So this guy is likely right-handed. It's very normal to see the side that you're dominant on, that shoulder is depressed. And then also the opposite side hip is laterally tilted down. probably because this guy's been reaching for lots of stuff with his right hand, maybe placing, oh, I don't know, if you were me, placing a kid or a grandbaby on your hip, right? So you can reach with your dominant hand. So here shows maybe a dominant left-handed guy. I don't see too much happening at the hips here, so it's a good thing to keep in mind is that we don't always see a pelvic issue with the handedness, but sometimes you do. Talk a little bit about the shoulder blades too. So from neither of these show ideal, but from the plumb line, ideally your scapula should lie about equidistant apart from the plumb line. Okay, so this is showing way too much scap retraction. I don't know who stands in that. Maybe somebody that's like standing at attention for the military or something. And you can see that, you know, they're completely not even close to the plumb line, equidistant apart at all. Here's showing somebody with too much scapular, looks like protraction here on the right side. You can see that these definitely are not equidistant. Just briefly on the knees here, good posture is important because it not only affects our spine, but it affects our knees and our feet. So with the plumb line, you should have a fairly equal distance between the patella, looking at an anterior view. You do not want to see too much pointing in of one patella or another. I'll talk more about on another slide that shows this better here. From the anterior view again, here we see this knee looks like it's a little bit more valgus than this knee. Okay, so it's coming in here just a little bit compared to a more ideal knee here. Both of these knees look like they're fairly in a valgus position. This person is doing some sort of compensation down here at the feet, looking like they're going actually on the outside of their foot, supinating too much, compensating for that position at the knee. And actually this might be, I can't really see the plumb line here, but it looks like this knee might be just a little bit more varus, and they're going out onto the outside of their foot here to compensate for that. You guys, it takes a lot of practice looking at different patients over the years to really know what you're looking for. I'll just show you this as a general starting point for you. So here we have some genu varum with the knee bow-legging out, and some genu valgum with the knee coming in. So this would be bow-legged and this would be knock-kneed. There you go again. Ideal alignment, the knee, the patella are equal, and bow-legged, you see they're curving out, okay, and postural knock-knees would be the inward curvature. So genu varum, genu valgum. Here's what it looks like with skin on, genu varum, genu valgum, with postural knock-knees going in together. Something to think about as we develop. Faulty posture is often a habit. So here's this toddler transitioning into childhood and then into young adulthood with some lordosis happening here at the cervical spine, getting progressively worse as their habits develop. Okay, the shoulders are getting to be much more forward here. This will only progress with time. You guys, it can always be corrected though. That's why good stretching comes into play and good strengthening comes into play. So it can be corrected no matter what age you are, with some good body awareness and some good retraining of those postural muscles. That's it for now. I cannot wait to see you in lab while we get into this. Have a good rest of your day, and I will see you soon.